that we're dealing with. I'm not sure if you can see all of this at the back, but it's largely indicative, because you've got sort of 10 million of referrals, GP referrals, accident emergency referrals, 20 million outpatient attendances, first outpatient attendances. This is all per annum. 12.6 million further appointment attendances. Overall, 50 million follow-up or 40 million follow-up attendances. And on top of that, 11 million inpatient ordinary admissions, 5.2 million inpatient day cases. And this is really about saying there's a huge volume of activity. This is all generating paper. This is all generating data. This data then needs to be stored. This data needs to be made available, retrieved, made available in whatever format. If we just look at the costs of manually managing that retrieval process, making that that available data, available where it's most needed, we're looking at something like 80 million records per year that need to be accessed across the NHS, and that could amount to a cost of 150 million in total. And that's a very, very conservative estimate. And anecdotally, I've heard tell of the average cost of moving information around a trust in the order of £8 million per annum or so. So there is a vast cost associated with the management of information. And I guess when I sort of look back to my previous experience and the work that I've done looking at supply chains, and I've got the mental model of an information supply chain, and really that's about embodying and delivering the core principles of an efficient supply chain, an effective supply chain. And in this case, it is about ensuring that we have an effective clinical process, that we support the ultimate mission of the NHS, that we don't have errors, that we get the right information to the right people at the right time. Again, analysis that's been carried out by the Audit Commission previously has pointed to the level of error rate that could be avoided if we can actually ensure that the logistics of achieving that objective are met. If we can avoid having incorrect information landing in the hands of the clinicians. And fundamentally, we can liberate a whole swathe of time that currently is focused on chasing up, trying to find, retrieving information, which is clinical time. So that's supporting the clinical objective. And as I just alluded to, we're talking about a cost-effective service as well. You've got staff, huge numbers of staff across the NHS engaged in manually supporting the process, storing, managing, looking after medical records. So all essential activity. Huge costs of storage, or storage that could be, or space that could be utilised for other purposes. And then a cost which, again, it's difficult to put a number to, and certainly I'm very keen to do some research in this area, but it's really understanding the flow of information around the organisation, the flow of information associated with the patient pathway, and just trying to understand how well managed that is. What are the delays? What are the activities involved in doing that, and what are the costs that are associated? I think my sense is that cost is quite significant. The other key, perhaps the key element of information management is management of the risk. And by information risk, essentially we mean this. It's all around ensuring that we retain the confidentiality, the integrity, and the availability of information. And that cuts across all formats. So if you think about that vast amount of information that's held, whether it's in paper form, whether it's in electronic form, in a hospital, in any organisation, in the NHS, that is a real challenge. And as we know, security of data is an increasing concern. We hear about people leaving laptops, stealing laptops, or people leaving USB sticks in car parks. There are concerns around the offshoring of activity, potential access to patient records, and then, obviously we've got the bigger concerns over centralisation of patient records, utilisation of things like Google and Microsoft and their health databases. It's a big issue for us, and there will be stronger enforcement of the security element around medical information as we go forward. However, it's my fervent belief that if we put those measures in place to ensure that we've got that security, we should automatically be enabling better information management. So that control gives us the opportunity to actually then look at optimizing how that information flows. So tighter regulations mean better efficiency. And I guess the key point there is we can't afford to neglect the risk element. We can't afford to ignore this. And I think this is the message is now getting through and is being sponsored at the most senior levels. And ultimately, with every organisation, this is about ensuring that we have continuity of critical business processes. And I just thought I'd share with you this. This is something that we've done with one organisation who are very, very mindful of their obligations to patients, and as a result have basically put posters up across the trust to educate patients and to invite patients to share their concerns as regards the sharing of data. The other thing I wanted to talk about really was the life cycle of information, and there are two aspects to this, and this is central, and this I think is central to what I want to do in my role with my organisation. And again, I need to understand it much more closely. But I think we've got to look at how we manage what we all believe is the right thing to do, the transition from physical data to electronic, to digital data, from the physical medical record to the electronic patient record. And I'm conscious that, again, this represents a fundamental logistical challenge. And I'm not sure everybody's alive to that. Not all organisations, where they've committed to such a programme, I'm not sure all organisations have thought through exactly what that logistical challenge looks like. It's not something that you can switch on to directly. There needs to be a very careful plan. There needs to be very careful management of this kind of hybrid process, this hybrid stage where you've got coexistent physical and electronic records. And that's something I think, again, you're looking at organisations that will be able to move. Some will move faster, some will move slower. I think we need to be able to clearly identify the pace of change here and set realistic expectations as to how quickly that can move. And there's a lot of noise and there's a lot of expectation that we can move to the end state and to start to deliver the benefits of having that information available where it's needed, and having that information available across a much wider network, a clinical network.